Go to it. Go. Good evening, good afternoon, or how are you doing? You are with us for another Wednesday evening edition of Wellness Watch right here on blackdoctor.org and the African American Wellness Project. We want to thank you for joining us. Again, of course, you know, I am your co-host, Ellis Dean from blackdoctor.org. And we've got a special show for you tonight. I am excited, a little bit excited, I guess. I'm a little bit, taken aback by tonight's show because we're going to be talking about something that's a little bit uncomfortable for men to talk about, and that is erectile dysfunction. So you don't want to miss tonight's guest about that. We also have a update with a friend of the show that's been on multiple times, Dr. Oliver Brooks, and he's going to give us the latest on the Delta variant with COVID and kind of give us some updates on where we are with our fight against COVID-19. We were winning at one point, but it seems like COVID is coming back with a vengeance. And so we've got to be very, very careful about what is going on with that particular virus, not just here in the United States, but all over the world as the Olympics are set to start later this month. But as before we begin our discussion tonight, we got a couple of things we want you to do, and one of the things we want you to do is to give us a shout out. Let us know where you're watching from. That means drop it in the comments. Tell us where you're watching from. Let us know how you're doing. Also, if you hear some content, if you know a friend that needs to hear this content, make sure you tag them and share it with your friends. Like the show. Let us know what you're doing and how you're doing, because that is always important to us. Finally, I want to let you know this show is interactive. I know that's a big word, but that means you ask the questions and we will answer them. And so make sure that if you've got a question, you drop it there in the comment section, and we will ask our experts your question on the air so you can get the answers that you need. So I think I've said all of the housekeeping items there. Dr. Lenore, how are you doing today, sir?
Well, I'm doing fine. I could say I almost forgot what I was doing. I almost forgot that I was part of the show. But I understand now we have to do this, and I appreciate that. No, I'm glad to be back with you this week. I think it's good that we have a mix of people. Erectile dysfunction is a subject that most men don't want to talk about, and I think, and maybe women as well. We'll ask Dr. Langford that question. But before we do that, Mr. Dean, I think we should talk with Dr. Oliver Brooks. He is our resident expert on what's happening with the COVID virus. There was almost a panic here in the Bay Area. There was an article written that in Marin County, 19 people were admitted to the intensive care unit. 18 of them had been vaccinated. And then and that went on for 24 hours, and then that had to be corrected. And so that, along with what's happening with the J&J vaccine, what's going on in terms of variants, I think there's just enough. I know people are tired of talking about the COVID virus, but I want to mention a few statistics before your interview. 99.5% of the people that die from COVID in this country are unvaccinated. That's the first thing. The second thing, in San Francisco, for every 1,000 white people who have the COVID virus infection, 2 people die. For every 1,000 Black people who have the infection, 15 people die. And so consequently, I'm tired, Mr. Dean. I know we've disagreed somewhat on this point, but I'm tired of people telling me that we can't tell people it's not okay to be vaccinated, that we should listen, and that we should be more considerate, more tolerant. No, I'm not in that particular position. My feeling is that if you're not vaccinated, you're a danger to yourself, you're a danger to your family, you're a danger to your friends. I think it's a very selfish attitude, and I don't think that with all the statistics that are out there that you can justify that particular position. But more and more, every time I talk to younger people especially, they are not vaccinated. And I just don't think that that's okay. And people may disagree with that, and probably several people do. but I don't think it's okay not to be vaccinated. Not one, not one iota of my being that believes that, and no need of me saying it.
Well, I definitely agree with your sentiment. I think the only thing we disagree on it is that um, I do think people have the freedom to make a decision. Now, I might disagree with their decision, but I do want to allow them that space and that freedom to make a decision. But you have every right to have a strong opinion about their decision. If they're making a decision not to be vaccinated, then you have every right to have an opinion about that decision. That is kind of the premise of this country in saying that we have freedom to choose and freedom to make those decisions. We also have freedom to have an opinion about those decisions, and so you have a strong opinion about that. I will say that shout out to Venus. I will say that we do need to be a little bit, especially the younger people, they need to be a little bit more cautious. And so that's why I'm excited to talk to Dr. Brooks tonight, because this Delta variant is taking out and it's really, really impacting younger people. I just read yesterday, as a matter of fact, in Mississippi, there were 12 children that were infected with the Delta variant. 10 ended up in the ICU, and these are young children. And so we're not just, and more and more younger people are being admitted to hospitals around the nation that are contracting the Delta variant. And so we see it's been called COVID on steroids, and it is proving to be just that, because it is now not just affecting the older population, it is affecting younger people as well. And they're finding themselves not as resistant as they once thought they were, as invincible as they once thought they were against COVID. They are being hospitalized and they're suffering the dire consequences. I will point that your statistic is right in line with the efficacy rate that was reported for the mRNA vaccinations. And so it is doing exactly what it said. It is meeting the efficacy. And so I know people wanted to hear 100%. They want it to be 100% effective. It's not, there's no vaccine that's 100% effective. But when you're talking about 99.5% of the people that are being admitted or that are dying from COVID are unvaccinated, I think the vaccine is doing its job. So let's bring on Dr. Brooks and hear what he has to say about this particular situation. Dr. Brooks, good evening.
Good evening. Good evening. So I want to link both of you in terms of your statements. So Ellis, you're saying that, freedom of choice is an American tradition. Dr. Lenore Mike is saying, I have no tolerance for those that are unvaccinated. Now, you made a point. There were children that got admitted to the hospital in Florida. If those children were under 12 years of age, they could not be vaccinated, which means that what Dr. Lenore is saying is that they got it probably from someone who was unvaccinated, and there's nothing that those children could have done. So that person, Dr. Lenore would say, was ultimately being selfish, is the term I would use. So if there's a continuum between total freedom of choice and then mandate, I'm leaning more toward toward Dr. Lenore. I actually gave a television interview last night that didn't get broadcast because the reporter got assaulted on her way to filing her a report. But I actually stated on there that I think we should consider mandates. I'm somewhat happy it didn't broadcast because I was actually worried about what effect that might have if it got out that, Dr. Brooks, that guy's talking about mandates. That being stated, there are mandates where if you have tuberculosis, the county will watch you take your medicines. You cannot go out. So I think that we're in a public health emergency. People are dying. This Delta variant is spreading. The rates are doubling, but they're 90% lower than the heights, let's say during the height of the pandemic issue. And what Dr. Lenore said is accurate. Studying here in Southern California, I think 5% of those that got it, that got the Delta variant were vaccinated. 95% are unvaccinated. The problem we have is with unvaccinated people. So I have to say that that's clear and present information, and they are a clear and present danger. So what do we do? Let me go one step further.
Yeah.
All this discussion is real interesting, but the bottom line is still the bottom line. You need to get vaccinated. You can talk to me about the Delta variant. You can talk to me about everything you want to talk about. Oh, it's only 98% or 58%. The emergency use authorization was going to accept a vaccine that was 50% effective.
Right.
because that's better than 0% effect. And side effects are minimal. You did mention J&J. J&J just came out that they are having some reports of a condition called Guillain-Barré, which is a paralysis. Again, the rates I think were somewhere around 12 per million. So again, if people start talking about that, okay, your chances of getting and dying from COVID are higher than the Guillain-Barré. So my opinion is this: I understand all of this is relevant, but at the end of the day, the answer is get vaccinated.
I guess the ultimate question is, why do you think people are still not getting vaccinated? Is it just because of the disinformation out there? Because I know on the more conservative leaning news programs, Fox, OAN, Newsmax, et cetera, Breitbart, et cetera, they have been staunchly anti-vaccination. They have been telling people go back to their lives. That the media is overplaying it, overblowing what's going on, and still people are in those predominantly, like Arkansas has now been called the epicenter of the Delta variant. So, and these are highly conservative states. So, is it just that people are not paying attention to what's happening around them and they're just listening to what they want to hear? Is it more affirmation than information that they're paying attention to?
So I think it's two things. When you look at the majority community, let's say Arkansas, I think it's a political question. Again, understand most of vaccine hesitancy and refusal is an emotional, psychological, and not a scientific response. I think that these people in the majority community feel that they are asserting themselves. No one's going to tell me what to do. If I told him, I want you to go pick up that $100 bill on the ground, they might say no just because I asked them to do it. So a lot of it is on that side is the political. There is some concern out there about side effects of the vaccine, but I think the highest rate of refusal of vaccine is white evangelicals, okay, and Republicans. So now for our people, for Black people, it's different. What I'm hearing is my vitamins, my working out, my good sleep, and my drinking water are going to boost my immune system. I'm waiting and seeing to see what happens with other people. And I just don't trust the vaccine. And then some, I think, are complacent. They're just not worried about COVID-19. So there are a lot of reasons. They're varied, but in the end, none of them have true scientific basis.
Yeah, I think the sad thing about what happened in the previous administration is everybody became a scientist, right? Immediately, right? And so now we've got all of these internet scientists that read an article or two and now are trying to refute what's happening. And so that's why I hear in the frustration from you and Dr. Lenore is that, you've dedicated your life to science and medicine and healing and helping others. And then you've got people that have done none of that in that learning to be able to understand this, and they're just telling you that you're wrong. All of a sudden you're wrong in your opinions. And so I can see from that perspective how frustrating that can be as a physician to say, wait a minute, I've looked at all the data.
Yes.
You haven't looked at you've looked at an article.
You remember that the lead physician toward the end of the last administration was a Dr. Atlas, who I believe was a neurosurgeon. Yes. And then they refuted Anthony Fauci, who is one of the 20 most quoted researchers in the world. And this was before COVID. So in other words, he was a highly respected doctor, one of the highest in the world. And they're refuting him. So you're right. It's like, if you remember way back in history, the church didn't want you. I'm talking about maybe a couple hundred years ago. The church did not want you to embrace science. They wanted to run dogma. So, I mean, I'm talking about 200 or 300 years ago. Now it's the same concept. We don't want science. We want to deny climate change. We want to deny that this vaccine works. And my thought is it's being done. So if you can convince people of that, you can probably convince them of anything. So it is really sad that this vaccine has become politicized. But in our community, what Dr. Lenore stated, 7.5 times higher rate of hospitalization among our African Americans. So our focus needs to be right now on our community, because the other, they can kind of afford to talk about it the way they're talking about it, be abstract, be political, be philosophical. We're dying. We're in the hospital. We get long COVID. So we have to convince our people that is in their best interest, it's in the community's best interest to get vaccinated.
Yeah, and it's interesting. Like, there was a comment here that says this very talk is why people won't get the vaccine, and I'm like, I don't understand what that means. What that question is, or what that statement is saying is that are they saying, is it because we're speaking more frank? We are. I don't know. I don't know how much more evidence is needed in order to suggest that the vaccines are safe, because there have been over now 350 million doses administered here in the United States with very few side effects. We've had some instances with J&J, a couple of instances with J&J. We've had people that have died. Yes, there have been people that have died that have been fully vaccinated, but it has been, when compared to the people that are unvaccinated that have died, it is a minuscule percentage. But if you're going to hold on to that and ignore the mountain of evidence to the other side, then there has to be some questions as to why that is. And so if we're questioning you and we're saying, why are you still holding on? Why are you still holding out against getting vaccinated? That's a legitimate question, not something that we're trying to insult your intelligence or trying to say. We're just trying to ask you a legitimate question as to, with the amount of evidence on this side and on the side that says vaccines are safe, generally people are being saved generally because of vaccines, and they're dying in greater numbers that are unvaccinated. Why are you still choosing to not get vaccinated?
Right, and that's the $64,000 question. The studies from Kaiser Family Foundation show that there's a core of about 8% of people who will refuse under any circumstances, and about 10% of people who will get vaccinated only if mandated. So we may be able to get to, if we can forget those 17% and get the 83%, we may get to herd immunity. And so we're focusing on that. It's a hard question to answer. I again, psychological and not scientific. I think some of it may be I have a rebellious spirit. I'm just not going to do what people recommend. I think that they may not be taking COVID seriously. Honestly, I just don't get it. There is a question in the chat box. After having received a coronavirus, after having had COVID and still having symptoms, when is it okay to get vaccinated? The general rule, and this is my rule, this is not necessarily recommended by the manufacturers, you wait 60 days from the time of you getting infection to get vaccinated. I would say if you're still having symptoms, I would probably hope, if you're not that far out, I theoretically would wait 60 days from the resolution of my symptoms to get vaccinated. So that's my answer to that. Ellis, I don't know. When you ask people, I get the main thing I get right now is I'm protecting myself with lifestyle and waiting and seeing, and then I don't trust the government. There's a microchip in there that affects my fertility. They don't know the long-term effects, but with vaccines, generally speaking, the side effects you see are early on. You don't tend to see side effects 2 and 3 years down the line. You see the side effects in the first 42 days, which is 6 weeks, and then maybe even going out as far as 6 months. We have studies going out as 6 months and even farther where we're not seeing any serious consequences.
I'd like to just make one final statement. I'm not really talking down to people who make this decision, because I'm not asking you to understand the science. What I'm asking you is to make the sacrifice for yourself and for your family and for your friends by getting vaccinated and keeping them out of danger. I think that's more a moral issue than it is an intellectual issue. I don't understand where all these scientists came from when you couldn't pass science in high school. I don't know where that came through. But I don't think that that's necessarily the issue. I think the issue is this, is that we do know that vaccines work. We do know that vaccines protect your family, your children, your friends. And if you're not willing to make that sacrifice, I think that's a whole different kind of decision. So thank you, Dr. Brooks. We're going to stay on this. Obviously, this is not a settled question, but I do appreciate your joining us. And we'll be talking in just a few minutes with Dr. Dawad Lankford. But before we do that, we have some other things to discuss. And you're welcome to stay around with us. We have this discussion. one of the things that I've looked at, I'm working with blackdoctor.org to put together a newsletter for doctors. And one of the things that I'm seeing in all of the articles and all the journals that I've been researching is it doesn't matter what the disease is. Most of the articles that involve African Americans are how they do worse with everything than any science that applies to them. Whether you're talking about cancer or diabetes, heart disease, stroke, kidney disease, or prostate cancer, all the articles in the journals on how much worse Black people do. There was a recent article released last week from the American Cancer Society, and it showed that Black people, that the death rates for cancer were going down by 2%, except for Black people. I mean, I looked at some issues that had to do with chronic kidney disease or with diabetes or prediabetes. And it seems that, especially for African-American men, are most at risk for all these diseases. And everybody's wondering why. And I'm wondering why. And I want to know what you think, Dr. Brooks, or what do you think? Tell us from your vast experience of talking to all these experts. Why is it, well, let me just say this. There are some environmental issues, no question. There are some genetic issues, no question. But there's some issues that are not easy to explain that have nothing to do with genetics and have nothing to do with the environment and have everything to do with the system.
So you mean why are we in fact at higher rates of everything bad and lower rates of everything good? Yes. So the reason is primarily, as you stated, the system, quote unquote. And there are a couple of things. Number one, so racism, let's just put it out there, okay? So racism causes you to have a chronic low level of stress, which increases hormonal secretions of cortisol and adrenaline, which leads to a higher allostatic or standard baseline blood pressure. Higher baseline blood pressure messes up everything. Other thing, and more, I think, that gets close to what you're talking about, because that's even scientific, is the way the system works. I mean, there are clear studies that show African Americans are less likely to get pain medications. They're less likely to get procedures that go with coronary artery disease. They're going to be sitting home with aspirin versus going to the cath lab and getting a coronary artery stents or bypass surgery. Black Lives Matter. That is so, people don't really realize how important that is. They're talking about with the police and social injustice, but in the ER, in the doctor's office, in the hospitals, we don't get the same care. So Black men are not necessarily getting their PSA checked as often. Black men are not getting that DRE, that digital rectal exam as often. They're not getting that low-level CT scanning for lung cancer. If you pick it up, you can be cured. Black women are not getting their mammograms as often. And then you get the social determinants of health. I can't get to the doctor because I got to work. I don't have a regular doctor. All of these things play into us having higher rates of everything bad and lower rates of everything good. So the answer is to focus on issues other than kind of what you're saying, Dr. Lenora, Mike, the things that we often focus on.
You know, if you're an African-American man or a Black man, what are the 5 things that you need to know about yourself from a medical perspective to assure that you're as healthy as you can be in the system? What are the 5 things? I mean, like blood pressure, obviously.
Can I take a stab at that?
Yeah, I may come up with 2. I was going to ask for that. I mean, I want with other people's
come to us.
Okay, so this is what I'm thinking. All right, blood pressure, your cholesterol, your PSA. So those are 3. I would say you should know your blood sugar, but if you're not diabetic, it might not be an issue. So
you should know your hemoglobin A1C.
Okay, hemoglobin A1C. So that's related to diabetes.
And that's that. But Ellis is also, because he said, like, I don't know what my A1C is right now, but I know I'm not diabetic or pre-diabetic. So, but it's funny though, because I wouldn't have answered that question that well. Although Ellis is fun, because I would have said, first of all, have a good relationship with have a primary care physician and have a good relationship with them. I'd say number 2, if you're married to have a girlfriend, have your woman book all your appointments, because if they leave it up to you, you'll never go. And I say number 3 is heed the advice of healthcare professionals. And simply, I was thinking, take your medicine. I'm sure anecdotally not only, that there are a whole lot of black men out there that have hypertension that have been prescribed antihypertensive that are not taking them. Same thing with your statins, same thing with your anti-diabetic medications. So I think that it gets kind of around to those things. And what you're saying, Alice, those are the things that would be taken care of if they did the things that I'm talking about.
But there are some numbers that you need to know. You
Okay.
got most of them, Ellis. Blood pressure, cholesterol, hemoglobin A1C. You need to know that. You need to know what your colonoscopy, situation is.
That is right.
And there's one I'm kind of missing, but those are the ones.
PSA for
PSA.
black men. PSA.
Those are the big five.
Right.
I mean, for women, it's still hypertension, it's still cholesterol, it's still hemoglobin A1C. It's your mammogram results. That's another thing. And I'm trying to
Maybe
think
cervical cancer screening.
and your cervical cancer screenings.
Absolutely.
But if you look at the statistics that we look at, it doesn't matter whether you carry a briefcase or whether you wear a tie or whether they call you, whether you're the CEO, CFO, CYO, BBO, it doesn't matter, because if you're black, then your death rates are much higher than whites, and your death rates are almost the same as brothers who are working in construction and other places. So we're all unified in that way. But if you know those several numbers, then I think that you can probably, get by and stay relatively healthy. I think that we at the Black, go ahead.
I think the piece that as a layman on this panel, one of the things that it took a while for me to sink in about my own medical history is how connected all of these things are. And so I did a show a few weeks ago about blood pressure and didn't realize how connected blood pressure was to strokes and other illnesses in the body. I thought a stroke was separate from the blood pressure, but when you see that just something as simple as having your blood pressure under control can have a greater effect on all of these other conditions within your body. Having your cholesterol under control has a greater impact on all of those other conditions. And so it really is all connected. We're going to be doing in a few weeks a series on liver disease, and not just, and when we hear liver disease, we just think about cirrhosis, which is connected to alcohol, but there's a whole host of other liver diseases that again affect black people at a higher rate, and affect black people at a higher rate that really has a greater effect. And we know how important the liver is in our overall body functioning. So I think in a general sense, well, and when we talked to Dr. Glenda when she's come on the show, and I think we need to stress this point more in terms of, so Dr. Brooks, I'm going to add a caveat to what you said about having listening to your healthcare provider. Also understanding being your own best health advocate and knowing the questions that you have to ask to go before you go in, and listening and being able to interpret what your medical provider is telling you. When he gives you a number, you should be able to, if your doctor gives you your PSA number, you should be able to know immediately whether that number is good or bad without him having to tell you. And that's just about being your own best health advocate and learning from African American Wellness Project, BlackDoctor.org, coming, watching these programs, going to reading articles, and understanding those numbers. So when they give you a report after you do your physical, you can be like, oh, I need to watch this. Oh, I need to do a better on that. And then that way you could be you'll be more adherent because now you're more invested into your medical process.
And you know what I would add to that also, which I think is a part of it. So I would even go more general, like take your health status seriously. Because if I were asking, if I told you that I could find a way to get you $100,000, but you need to go on the internet to find out how to do it, I give you some non-specific information. You need the specifics, then you'd be on the internet all day trying to get to that $500,000. So if you were like, I know the doc said I have borderline hypertension. What does borderline mean? And then go look it up. So in other words, have an interest in your numbers, care about it. Because I think that probably men, period. That's why I said the women every year. I don't care what you say. We tend to think that we're impervious, that we are going to be well. Part of macho is I can do anything, I can be anything. So I really believe that if you start taking your health status seriously, you'll start to do those things that you said. And I do agree with that. I went to my doctor and I got my labs back and my cholesterol was elevated. I never heard from my doctor. So I have to go forward and get you. I should have called him and followed up. My position is okay. I'm I'm going on my own way and talk to my own doctor, people I know.
And it's bad. I mean, it's bad, and it's really bad in that system. I say that if I'm in a strange city, like Florida or where you are, or in Los Angeles, and I get some chest pain or something happen, I'm gonna try to get in a suit and get me a briefcase before I go to the emergency room. I'm not going in my pajamas. Don't go to the. Here's a tip: don't go to the emergency room in your pajamas unless you just can't help it, because you'll get pajama type medical care if you're in your pajamas. Now, if you put on a suit and take a briefcase down there and maybe try to look important, talk about the mayor, your friend or something like that, you might get some attention. But do not, this is the tip, it's not in the books, it's not anywhere, but do not go to the emergency room in your briefcase. That's when you said, that's you get pajama type medical care.
Whenever I'm seeking medical care, even my own doctors, I ensure that I am well dressed. And that's the truth, because what you said is absolutely true. What people may forget is doctors in the healthcare system are nothing but a bunch of trained individuals. And so people are human. People look at you and you come in there with a suit and a tie and you're talking about, the mayor. Yeah. You walk in there again with your house shoes. This is what my pet peeve, people walking around with house shoes. And I look at them, I know they got, in America, the poor people are obese with cell phones and gold jewelry and fancy shoes. So I don't know how poor you are, but I know you got a pair of shoes at home. So don't come into me wearing your house shoes. Don't go to the ER wearing your house shoes, because you will get disrespected. So I think that is, people should not laugh at that. That's real.
It is real. It's a part of and from a psychological standpoint, it's called a nonverbal communication, right? So you're sending signals both verbally, what you say, and you're also sending signals by what you do physically and how you dress, your appearance. And so a lot of times, some people take offense about that because they say, I'm an adult, I can wear what I want to wear. It shouldn't matter what I wear. But again, we are always communicating. Whether we're not saying a word, we're still communicating. And wearing house shoes, wearing bonnets, wearing pajamas, as Dr. Lenore suggested, is sending the message to that doctor that you're not as invested into your medical care as you should be. And whether that could be completely wrong, that could be a completely wrong assessment. However, that's the message that's being sent. And so that's the message that they're typically going to receive. And so therefore they're like, I'm not going to spend as much time with this patient because I only have a limited amount of time. And this patient is not as invested as somebody that may have come in with a button-down shirt on, with a tie, carrying the briefcase, doing all the things that Dr. Lenore said, because that patient appears to be more invested in their medical health in terms of their long-term health. And so therefore, I'm going to give them the time and attention that their nonverbal communication is sending to me.
Yeah, my grandmother used to say there is what is, and there's what ought to be. And you ought to get the same level of treatment. There's something that we keep talking about every single week, and that's unconscious bias. And that means that the system looks at you as an African American very differently. I can remember not too long ago, I went to Nordstrom's Rack. Now, you're in Nordstrom's Rack. There's a certain level of appreciation you have for low income something. There was some guy that followed me around Nordstrom. Every rack I went into, he went into. I went way over to look at some shoes, and he followed me over there. So finally I looked at him and said, man, you everywhere I am, you are. He said, just coincidence. I said, no, this is not coincidence. There's nothing coincidental about this. I was in the Safeway Superstore. And there's this gentleman who came in, a very distinguished looking Chinese gentleman pushing the rack around. I went from oranges to liquor to Cheerios to the bread, and he followed me everywhere I was. He was. So I said, it certainly is I was loud too. It certainly is coincidental that you're following me around in all these various places. Do we have the same shopping list? I know he just kind of said, and he disappeared and went over to some other area. So you really have to recognize that unconscious bias is a real problem. We'll talk about that in subsequent weeks. But now, finally, the man of the hour has joined us. I assume there was some kind of a urologic emergency that prevented Dr. Lankford from joining us, but we're glad to have it. Dr. DeWan Langford.
We're about to make I was about to say a hard turn, but I think that's going to be what we're talking about. It's not so hard, but what we're talking about, we're going to take a sharp turn from our discussion.
Ellis, really? Ellis.
From our discussion, and we're going to talk about something that's uncomfortable for most men to discuss, and that is erectile dysfunction. So welcome, Dr. Langford. We understand that your schedule is as tight as it is. So thank you for giving us the time this evening.
All right, well, let me introduce Dr. DeWan Langford. Dr. Langford is a urologist in the San Francisco Bay Area. He's a graduate of Meharry Medical College, and he interned at the University of Southern California, did his urology somewhere in New York, I think, and did a fellowship in New York. And
New York Medical College.
Where?
New York Medical College. It's in Westchester.
Yeah, it's funny how, when you go to medical school, you always mention the last place you went, never the first place. But we're glad that you joined us. And we're going to talk to you about erectile dysfunction. It's something that most men don't want to talk about, maybe women as well. We're going to ask you about that. And we have a series of questions to ask, and we hope the audience has some questions to ask as well. So why don't we start our interview with you defining erectile dysfunction for us.
Sure, and thank you for having me. Yeah, it can get a little hectic on that 880 freeway, that corridor. Anyway, erectile dysfunction. Basically, I think the best way to describe erectile dysfunction for those that are struggling with this issue or this disease is the inability to get an erection that's satisfactory for that individual. And that's, again, the inability, not being able to get a satisfactory erection so that they can have a pleasurable experience during sexual intercourse. And so a lot of times, men will describe their symptoms of being, I don't get the erection that I want to get, and that can be erectile dysfunction. Also, it can be the inability at all to get an erection. Okay.
Now, how common is it? I mean, obviously, I'm not talking about the occasional failure, where you have a problem. But how common, how often do you see that?
There was a large study done in Massachusetts. Few people quote it because it's rather, it was in a sub-select population, mostly all white males, mostly in the Northeast. But they found 40% of people are affected by erectile dysfunction at the age of 40, 50 at 50, 60 at 60. What we can say, we can't sort of extrapolate, we can't say that's true for the whole country, for every individual population group. But I think what we can say, Dr. Lenore, is that it's very common. Odds are, if you're talking to, 10 people, up to 30 to 40% of those people are going to say they had a problem with erections at some point in time.
Now, we're not talking about people who had urologic surgery or anything else, but how do most cases of erectile dysfunction start?
Yeah, most of the time, a gentleman is trying to enjoy himself and trying to have sexual intercourse, and he can't get an erection. And it happens a lot of times sort of in the most worst of times, And so if that happens once, they may, chalk it up to, hey, maybe I was drinking that night, or maybe, maybe it was a fluke. It happens 2 times, they're coming to the urologist, they're going to their doctor immediately as fast as possible. So most erections sort of start with the inability, having the problem with having erections when they're trying to have sexual intercourse or trying to have a sexual experience.
But, that then creates a sense of anxiety. So does that mean that most of these cases are anxiety only, or is it, how can you tell when you really got a problem as opposed to when you're just anxious about being able to produce?
No, that's a good question. I think So I tell people this. I say that erectile dysfunction is 75% mental, 25% physical. There are physical issues that cause erectile dysfunction, i.e., vascular problems, blood pressure problems, diabetes problems. Okay. Also, if you've had previous surgeries in the pelvis, if you had a trauma in the pelvis, and if you've had prostate cancer, or cancers in that area, rectal cancer can also contribute to erectile dysfunction. Also, injuries to the spinal cord as well. And if you have anxiety, because a lot of the erections themselves can come from sort of, having anxiety and not being all together there. All those can contribute to erectile dysfunction, I think. And you kind of, every time you talk to an individual, you kind of got to get a history, see what they're dealing with, seeing if it's an anxious time, or see if there's something more telling in their history that points to a physical or an organic cause.
Now, what do you tell your patients who you see this is their first or second episode, they're a little anxious, but if you leave that cycle going, it just kind of escalates to something much more serious. How can you break that cycle of anxiety? What are some of the things that you recommend before we start to talk about the more serious cases and the treatment of those cases?
Yeah, a lot of times as doctors, I think we have to think outside of the box. We have to look at a holistic approach to what causes disease. And so a lot of times the anxiety has to do with job loss, or especially during this COVID crisis. And we're going to talk about COVID, how COVID can be related to erectile dysfunction as well later on. But I think that, it's important just to get an assessment of where you're at. Where are you at right now with your life? How's life going? And so I sort of use that to steer me towards, some of their more stressful issues. And then we talk about stress alleviation. I mean, I think that one of the major recommendations that I give to patients is exercise. Exercise probably is the most important form of stress relief. And then also it can help you on the back end by improving your overall health, improving your circulation. And that's one thing that's critical with erectile dysfunction. I think that every man needs to know. I say that the penis is the window into the heart. It's the window into the brain.
Wait a minute. I've heard a lot of expressions, but is this something that you made? This something you made up?
No.
You saw this somewhere else.
I didn't say the penis was the way to the heart. I said the penis is the window into the heart or into your cardiac health. If you're having erectile dysfunction that could be related to vascular issues, to overall health, it could be showing us that you have early heart disease. Could be showing us that you have vascular disease that also affects the brain and affects the rest of the body.
Our special guest is Dr. Ward Langford. He is a urologist. We're talking about a rather sensitive subject, which is erectile dysfunction. If you want to join us, get in the chat room, ask Dr. Langford a question. This is kind of a place where we encourage that. We have a question about high blood pressure causing an issue with ejaculation.
All right, high blood pressure. So a lot of the blood pressure medications regulate your blood pressure. What causes erections? Blood pressure. It's different kinds of blood pressure. So there's certain vessels, blood vessels, that dilate to cause for the spongious tissue that causes erections to fill. And so when you have a blood pressure medication that's lowering your blood pressure, that's lowering the ability to fill blood into your penis. The mechanism is a little bit more complicated than that, but to break it down, low blood pressure or the blood pressure, that could be a side effect of your blood pressure medications. So that's important to review with your primary care doctor and let them know, hey, listen, since we've started this new blood pressure medication, my erections aren't the same. And then they can either discuss that the dosage that they're giving you for that blood pressure medication and maybe change that change to a new blood pressure medication, or go ahead and see your urologist, and we can talk about ways to treat the actual erectile dysfunction.
Yeah, I think that one of the statistics that always stands out to me when people talk about hypertension is that one of the reasons men stop taking medication for hypertension is because it does affect erectile function. And so consequently, it is important that some of the newer medicines really have been designed so that that doesn't happen. Now, when we talk about true erectile dysfunction, the first thing I think we talk about are the Viagra type drugs. I refer to them as the Viagra type drugs because Viagra got the most publicity. Where do they, when you start talking about treatment of just the average person, the average man, not one who's got, prostate cancer or neurologic issues, where do these medicines fit?
So, it's a stepwise fashion, the way we evaluate a patient, right? We're going to look at you and we're going to see your whole history, right? We're going to look at an outlook, okay? All right, do you have anxiety? Anxiety plays a significant role, and we want to try to alleviate that anxiety and see if the erectile dysfunction gets better. Now, if you have physical issues like blood pressure issues, diabetes, we want to optimize those, all right? We also want you to exercise. If you're a little bit overweight, we would say, hey, listen, maybe you need to exercise, optimize your weight, and that will improve your erections. And if all of those things fail, then we start to talk about, okay, how do we treat these with medications? The first line in medication, we call these phosphodiesterase inhibitors. It's an enzyme that works at the penis level. And this enzyme is involved in helping the penis fill. And so what we do is give a medication that blocks this enzyme, or it interacts with this enzyme to allow for better filling of your penis with blood. And so that's how these medications work. And that's the first line. That's the trial run, if you will. That's what we do off the bat. And if those fail, then we go down the line to more invasive procedures or more invasive treatments.
Are any of these medicines better than any other? Like is Cialis better than Viagra, or Viagra better than some of the others?
That's a good question. A lot of people ask that question. Everybody. Oh man, I want to get the Levitra. The Levitra is better than the Stendra. The Stendra is better than the Viagra. And so the thing is they all act via the same mechanism, right? They all are pretty much involved with the same mechanism. But sorry, trying to get my lighting a little bit better. But every medication has a different formulary, and those formularies interact with each individual's body differently. And so sometimes it's a little bit of a trial run. We may try Viagra first, and maybe that works well, or maybe that doesn't work so well. So then we say, you know what, let's go ahead and try the Cialis. The Cialis may work better, and maybe that doesn't work well. Then we go down the line. The problem is that a lot of these medications can be expensive, and sometimes I use that to judge, okay, listen, we've already wasted money on Viagra. It's not working at all for you. Maybe we should go to the next step. What is the next step? So, so we talk about the oral medications, and then we talk about, along sort of parallel with oral medications, there's something called Muse, and that's a medication that gets injected into the urethra itself to cause an erection.
How we get that far? But go ahead, please.
Yeah, so it's a little bit painful, but it directly interacts with the tissues through the urethra. It diffuses into the tissues that become erect in the penis. This can sometimes be a little bit painful in the urethra itself, but some people who don't want to do the pills or feel like the pills aren't working may want to try this, because when I tell you about the next step, it may be a little bit too invasive for somebody. And the next step is really injections with an injectable needle.
How desperate do you have to be to take that step? And this is a serious question. Obviously, this is not the easiest thing to do, but what in your experience, what pushes a man to go this far?
Well, I don't know if it's too far. I think
They're going to sleep.
I don't think so. I think, the thing is, people inject for insulin every day, right? If you're a diabetic, you have to inject every single day for your diabetes. People inject every single day for epinephrine pins if they have allergic reactions and things of that nature. So injecting your penis prior to sexual intercourse is I wouldn't say it's too drastic. But then again, I'm a urologist.
I hate to ask you some other questions if that's your answer to this one. But in any event, I can understand, like I say, but what is it? Is it just is it the need to perform, or is it the lost sensations, the pleasure of it that pushes a person to go to the injection phase? I mean, not that I'm criticizing that, I'm not. I'm just trying to understand in your patient population, what are the motivations for most of the men who want this type of treatment?
So injections, usually we use those when the oral medications have failed. When the oral medications have failed, when they do not work, then we go to injections, okay? And there are some steps in between, like the injectables into the urethra itself. There's also a vacuum-assisted device. It's a vacuum device where you would constrict the blood flow from going outside of the penis with the ring type mechanism, and you use a vacuum-assisted device that sort of evacuates air to help the penis stay erect. Okay, those are sort of parallel with the medications because they're not invasive, and they're not a medication, but they are a little bit quality of life effectors.
Yeah, that's the pump.
The penile pump. Well,
you're very formal with it when you said the vacuum and all that other stuff. And I was like, it sounds like a pump.
So some people call the penile pump. They will call that the penile prosthesis, which is sort of the most invasive step in penile surgery. And the penile prosthesis is an insert. So first we start with the pills, okay? Then after the pills, penile vacuum-assisted device is what is the technical term for it, which is, we wouldn't call that the pump, we call it more the vacuum.
Right.
Okay. Yeah. Then there's injections, right? We have the Muse, which is the urethral injections. Right before that, that's kind of with the vacuum-assisted device. Injections, and then after injections, if the injections don't work, or some people feel like they're too painful to inject, we have the penile prosthesis. But let me say one more thing about the injections. And Dr. Lenore asked a question about the injections. What pushes someone to do injections? And I think the injections are usually used when the oral medications don't work. A lot of times when someone has prostate surgery, right? Prostate surgery, if the nerves have been damaged, maybe the medicines don't work as well. So the injections sometimes work a lot better because the medication is delivered directly to the penis, right? Versus having to go through your mouth, through your blood system, and then to the penis. And so that's a lot more or less when we do use injections. And some people like to do the injections. They find it, you don't have to take a medication where you have some of the side effects. When you can take some of these Viagra type medications, we call them the phosphodiesterase inhibitors. These medications can cause you to have blue halos. You can see funny. You may have some nasal congestion. And I'm sure a lot of our callers and our viewers probably know what I'm talking about when they've taken some Viagra. I'm not going to say anybody on this phone call right now. I know all of you don't need it.
I'd be ready to step up, but no need to get personal. One of the things before we go on to the ultimate involved issue is how effective is marijuana in patients who have erectile dysfunction?
That's a good question. I never used it to treat people with erectile dysfunction, but I can say chronic use. Sometimes I see people having difficulties obtaining erections if they're a chronic marijuana smoker, daily smoker. There has been some data to show that it does increase estrogen levels, and sometimes there's breast tenderness associated with abuse of marijuana, THC. But overall, I find it a great medication for anti-inflammatory and for anti-anxiety.
Okay.
But you don't think that works in mild cases, and maybe even at the same level where some of the pills may work? Has that been your experience?
I would say no. I would say in my experience, I have not. There's two other treatments I should mention. There's something called shockwave therapy. A lot of people ask questions about the shockwave therapy. I reviewed the American Urologic Association guidelines, and shockwave therapy should be viewed as something that's experimental at this stage now. It is not something that's seen as a tried and true FDA approved, or I wouldn't mention FDA, but I would say it's not seen as something that in the pathway that we would use definitively. It's something that if someone asked, they could go out and seek these therapies and treatments, probably safely, but they're seen as experimental. Also, there's injections of plasma-rich PRP injections, and this is something that can be injected into the cavernosa of the penis directly. That is also seen as experimental as well.
Let me ask you, we here in the Bay Area, we always hear, and maybe you hear it in Atlanta, other places, that there are these men's health clinics that guarantee 99% success in dealing with erectile dysfunction. How, in your experience, how successful are they? Should they be avoided, or are these fairly legitimate ways to deal with this issue?
So I'm not sure. I mean, I'm always weary of anybody guaranteeing anything. I think that there's nothing that's absolute, but I do believe that some of our treatments are very successful. So we were talking about the steps and treatments. We talked about first starting with the oral medications, and then going to intraurethral injections or of Muse or the vacuum assisted. And we talked about the injections of the prostaglandin injections into the penis itself. And then last but not least, there's the penile prosthesis. The penile prosthesis is a insert of an inflatable mechanism that helps you to obtain an erection without being able to obtain it yourself. So basically, it's an inflatable prosthetic that's placed inside the penis, inside the body during surgery, that you can then pump up via a pump that's in the testicle. When they do satisfaction surveys, that has been seen to have an 80 to 90%, even upwards of 90% success rate. So these men's clinics may be by default quoting these success rates from penile prosthesis surveys. But I don't think that in general, any men's clinic can give you a success rate of their treatments, because I mean, every person is different, and every treatment has a different success rate.
I got a question in terms of, like, I'm talking from more of a sociological society standpoint, when you're talking about how Black men are viewed in this country, in terms of being, kind of all the narratives that have been created around Black men, especially in considering our sexuality. Do you think that plays a role in terms of, if we start having ED problems, that we're less likely to go see a urologist and more likely to maybe to go to those men clinics, or go to buy something that's offline, like you see those mail where you could just do a consultation online and get it sent to the mail, versus going in and working with a healthcare professional like yourself?
Yes, I 100% agree. Societies culture plays a major part in what we call shared decision making when deciding treatment options. If you look in the Latino, Chicano Latino, or the Latinx community, you see that there is heightened awareness for sexual dysfunction. many men will come in already asking for la bombita, which is the actual penile prosthesis pump that's placed inside to in the body via surgery. Whereas I would say some men come in and it's not something that's spoken about in their community very regularly, openly. I would say from my own personal experience with African American men, I don't believe that these sexual issues are spoken of very regularly. However, I do have a slew of men who may tell their friend, "Hey, this is my good friend. I told him that I got it. It's working." I even have 2 patients who had children by the same woman, and they're friends, and they both talked with each other while going to a birthday party at the same house, and they both got penile prostheses because they both talked to each other. They both had a history of prostate cancer. So they helped each other through their prostate cancer trip and journey, and they both helped each other obtain the penile prosthesis, and both are 99% satisfied.
Yeah, how many of these do you do a year? I mean, is it like one a month or on a more than that?
I'm probably one of the busiest individuals here in the Bay Area. It's hard. Sometimes I don't like to quote numbers on time, but I can say that I do a significant amount of these. Good stuff.
That sounds like a cop out.
Yeah, I can neither confirm nor deny these numbers, but I can say
you're not putting names. It's just math.
One of the things that would be interesting, because we're running out of time, unfortunately, is that next time we talk about this, you could bring some of these devices so we can actually see the device itself.
That
would help demystify, if that's the term I'm looking for. You would demystify some of the issues around erectile dysfunction. I think it is a much more, and we're not making light of it at all. I think we think it's much more of a problem than we're willing to admit in our culture. So thank you, Dr. Langford, for taking the time to join us. And I know the people on 880 thank you for the other 30 minutes that you had, but we appreciate it.
We're going to bring it back. We're going to bring it back. I'm going to show you guys some prostheses. We could talk about the surgery.
Right. No, we look forward. Well, I don't say look forward, but look, I don't know what we should say exactly. But no, we appreciate your taking the time. We know how important the problem this is, and we appreciate the opportunity to talk.
I got one last question. Is it an early sign of prostate cancer? Is that a warning sign of ED?
So erectile dysfunction is associated with prostate cancer. It's one of the quality of life concerns when someone has prostate cancer. Okay. So that's one of the things we look at. Now, down the line, treating ED is a strategy for treating people after they've recuperated from prostate cancer. Okay. So early penile rehabilitation with oral medications. Of course, if those don't work, we go to injections. And of course, if those don't work, I advocate for placing the penile prosthesis as soon as possible so you can return back to your normal life.
Well, one of the things you always talk about after surgery is diet and exercise. I mean, there's certain exercises that you recommend after certain, surgery.
Yes.
Like this.
I have a pelvic floor rehabilitation regimen that I have all my patients do after pelvic surgery. Also, exercise and diet and losing weight is critical in optimizing your cardiovascular system. It helps in direction. These things started immediately because the shorter amount of time that you don't change from what you've done your whole life, the better you feel psychologically.
All right. Well, thank you very much.
Counseling to that whole situation to reduce anxiety and to get over the fact that.
Well, thank you.
There's life after erectile dysfunction. Don't worry, fellas. We can get you back. We can get you moving and grooving again. Don't worry. Don't listen to these guys. I'm telling you, it's okay.
We haven't said anything. What do we're bringing this to the general public. I mean, I don't think that we're not advocates for this kind of thing, but you do seem a little enthusiastic.
Listen. We haven't even talked about penile enlargement surgery too.
No, I don't think that's not on the agenda today.
There's some new techniques out there. We need to tell about it.
Yeah. Thank you, Dr. Langford.
Put off the rails with this
Yeah,
conversation.
no, I think that would be an interesting subject. But
It would be.
but thank you for joining us on today's edition. You're always welcome to come and talk to us about urologic issues. I think this is an important issue. And I'd like to thank Dr. Brooks always for updating us on the coronavirus and COVID virus infections. But most of all, I'd like to thank a lot of people for joining us on a regular basis here on the Welcome Watch. We want you to talk to your friends about our program. You always have an opportunity to come and ask questions. So I want you to remember that health is your biggest asset. And thanks to Mr. Dan, and thanks for Mignon for putting some of this together. So next week we'll be talking to you from the National Medical Association Convention. We hope to have the incoming president to talk about what the agenda looks like for the largest African American organization of physicians. So remember, health is your biggest asset. Once again, we'll talk again next week.